Hi, everybody. You are listening to the Medea podcast series. Medea Medical Education Academy is a global medical education provider dedicated to designing, delivering, and evaluating medical education programs worldwide. Today, we will be speaking with Guillermo Umpierrez, Professor of Medicine in the Division of Endocrinology at Emory University School of Medicine in Atlanta, Georgia, and the 2022 President of the American Diabetes Association. This podcast is part of the continuing medical education program entitled Prediabetes/Intermediate Hyperglycemia and Diabetes. Diagnosis, Guidelines and Management for 2025, targeting clinicians involved in endocrinology, particularly diabetes, prediabetes, intermediate hyperglycemia, obesity management, and general practice. Some content may be of interest to vascular specialists and cardiologists.
Hello, I'm Guillermo Umpierrez. I'm a professor of medicine at Emory University School of Medicine. It is my pleasure to discuss with you about prediabetes and intermediate hyperglycemia and the risk to progress to diabetes. We will discuss how to recognize prediabetes and what risk factors for comorbidities. We will discuss how to understand comorbidities and the role they play in clinical outcome in individuals with overweight and obesity. In addition, we will understand the potential applications of new prediabetes treatment in preventing the development of diabetes. Finally, we will give you some important clinical tips how to manage prediabetes and intermediate hyperglycemia in the real world.
What are the main comorbidities associated with prediabetes/intermediate hyperglycemia?
The main risk factor for prediabetes and intermediate hyperglycemia are increased body weight, obesity, and overweight are perhaps the number one risk factors, and we have seen an increase in the past 20 years of both prediabetes and also obesity. So if you look around in the United States, there's about 38 million people with diabetes. And there we have about 98 million people with prediabetes. But this is not a United States problem. This is a global problem. Diabetes has increased from 135 million people in the year 2000 to over 550 million in 2024. When you ask yourself what's the prevalence of prediabetes, it's somewhere around 15% in the world, with a global impact of 762 million. So if you look around, why so much? Well, in part has to be that the population is aging. We don't move like we used to do, so we're very sedentary. And unfortunately, the prevalence of obesity now has increased significantly.
How may identifying the different phenotypes of prediabetes/intermediate hyperglycemia lead to individualized treatment schedule?
The diagnosis of prediabetes is based on glycemia measurement. So everybody who is overweight or obese, who has a body mass index greater than 25, should be screened. We used to say over the age of 45. Now we say that everybody, even if you are not obese, should have a diagnostic test to rule out prediabetes or diabetes. These include a fasting glucose, an oral glucose tolerance, or a hemoglobin A1C. All of these three tests, the fasting glucose, the OGTT, and hemoglobin A1C, are good. Two tests better than one. So when we consider who is a real risk, we have learned that those who have a BMI greater than 35, those who have a fasting blood glucose between 110 to 125, or a hemoglobin A1C greater than 6, are those who are going to progress to diabetes. In addition, a history of gestational diabetes in females, of course, is a tremendous risk factor that is going to result in a progression to diabetes. So why this is important, looking at the level of blood glucose and body weight, is that there are two different types, those who progress and not. And those who have higher blood glucose, 110 to 125, and hemoglobin A1c greater than 6, those are at high risk, and those are the individuals that the American Diabetes Association and the global recommendations are to intervene. So refer them to a diet intervention, to a lifestyle intervention program, exercise, in addition to consider medications early on to prevent diabetes.
Currently, what biomarkers accurately diagnose prediabetes/intermediate hyperglycemia?
As I mentioned before, the best way to diagnose prediabetes is measuring blood glucose. And this can be done by fasting blood glucose, hemoglobin A1c, and is seldom done an oral glucose tolerance test. They have a good history based on how much weight have you gained in the last few months or years. Second, what about your physical activity? Because those are the individuals who are going to progress. Right now, we have around the world over 1 billion people who are obese. 39% of adults in the world are overweight or obese, and we are anticipating that 50% in the next 5 years will be obese, at least in the United States. So what we want to do is early intervention. And we start with lifestyle, diet and exercise, with the goal to lose about 7% of body weight. Just 7%. Because multiple studies have shown that losing 5 to 7% of body weight prevent the progression from prediabetes or intermediate hyperglycemia to diabetes. So there are studies in the United States, in Europe, in Japan, in China, all over the world. Lifestyle is the first step. Now, we also have learned that losing weight is hard to do. And of those, for example, in the National Diabetes Prevention Program in the United States, only 35% achieve 5% of body weight despite intensive interventions. And physical activity, less than 40% achieve to do 150 minutes, what is the recommended time to do exercise. But we should not despair in the way that we know that weight loss is important. If you lose just 2 kilos or 5 kilos or 2% or 5% of body weight, you decrease the risk of diabetes. So, but more importantly, what we try to do is to achieve a 7%. If that's not enough, well, intervention with multiple medications have been shown to be effective.
How do you manage prediabetes/intermediate hyperglycemia in clinical practice?
This is a day-to-day problem in the way that we know that 80% of patients or individuals who have prediabetes or diabetes are overweight or obese. So the first thing is to take a good history about how the obesity or weight problem occur, how long. Because the longer you have obesity and prediabetes, the harder it is to start a lifestyle intervention. So we should start early on. The younger the individual is, that's when we have to start, in the adolescent, in the children, adolescent, young adult. Don't wait until you're 60, 70 years old, because it's hard to start doing that and exercise when you get in the older adult. So the first thing is lifestyle intervention. The second is consider medications that are used to control diabetes or used for the treatment of diabetes or body weight. And there are multiple studies all over the world that have shown that glucose-lowering medications are effective. Similarly, medications that are for weight loss are highly effective. Clinical studies have shown that the use of metformin perhaps is the #1 agent used around the world. The American Diabetes Association recommends metformin at the first line for those who have mild hyperglycemia. As I mentioned before, glucose between 110 to 125, hemoglobin A1C greater than 6.1. Don't wait until you get diabetes. Start metformin. But now we know that multiple medicines are very effective, especially those associated with weight loss. So if you have medications, for example, phentermine, topiramate, have been shown to be successful in the sequel pre-diabetes studies. Studies about 500 individuals, they have a 50% reduction, and with diet and exercise, that increased to about 80% if you lose weight. Same, the use of GLP-1 receptor agonists. Liraglutide, that is available all over the world now in the United States, is generic. The SCALE obesity trial prevented diabetes or progression from pre-diabetes to diabetes after a year of intervention in about 70%. With the new agent that we have, weekly GLP-1 receptor antagonists, doses that semaglutide once weekly of 2.4 milligrams are associated with 10 to 12% decrease in body weight and 90 to 95 regression from hyperglycemia or intermediate hyperglycemia of prediabetes to a normal blood glucose. Similarly, the tirzepatide, the dual GIP GLP-1 one weekly for the treatment of obesity in individuals with prediabetes, you can prevent the progression in about 95%. So we learn that diet and exercise is the way to go. And it doesn't matter how to lose weight. You can do bariatric surgery or look at the data on bariatric surgery, where 90% of patients, when they lose the 30% with surgery, they normalize blood glucose concentration. We recently even have data that if you progress from prediabetes to diabetes, and you intervene for weight loss with diet or exercise or with medications, you can produce regression of diabetes, or what is called remission of diabetes. So current recommendations are, first, screen. Do a glucose testing, a fasting blood glucose or hemoglobin A1C. If you have any doubt, use an oral glucose tolerance test. Do it early on. In individuals who are obese, overweight, start even less than age 20. The recommendations are everybody who is over the age of 35, independent of body weight, should be tested. Because this is an asymptomatic with 90% of those who have intermediate hyperglycemia or prediabetes don't know they have the disease. And consider early intervention with metformin or other therapy when in obese patients and those who have a history of gestational diabetes and rising hemoglobin A1C. Don't wait until you have the disease, because prediabetes is associated with increased cardiovascular, renal, and multiple complications. And what is the future? The future is early screening. We have 88 million people in the United States, over 600 million around the world with prediabetes, and the progression in different populations goes between 8% to 20% per year. So if I tell you that you have prediabetes, you have about 50% chances to progress to diabetes unless you intervene. And lifestyle medications have been shown to be highly effective.
What take-home messages do we have at the end of this podcast?
We have learned during the past 2 decades that both diabetes, prediabetes, and intermediate hyperglycemia is close to be a pandemic, in the way that we have double or triple, and in some countries will have increased the rate of diabetes and prediabetes by 4-fold. Most important things to take home is that lifestyle interventions are effective and appropriate for diabetes prevention. They're difficult to follow, but they're effective. They have a high percentage of failure because there is little weight reduction. And in those who are successful in losing weight, there is a fight. They have a fight for the rest of their life because the body is trying to regain body weight. And unless you do exercise and continue with lifestyle intervention, there is a risk that you're going to progress again to diabetes. It is important to take in consideration that pharmacological intervention in conjunction with lifestyle changes, not just medications itself, it has to be combined with lifestyle, are much more effective in high-risk individuals. So, what intervention? Medications that have been shown to be effective are metformin, and every drug that is used for diabetes has been shown to be effective, with the exception of sulfonylureas. So we recommend, because they're safe, they're effective, we have learned for the past 40 years metformin is the first line agent. Now, if you have obesity, then you have to start working on the obesity paradigm. You have to use lifestyle intervention with medications that have been associated with weight loss. And of course, the number one is a GLP-1 receptor agonist these days. But there are other medicines that have been shown to be effective in weight loss. Finally, we have to consider that prediabetes and intermediate hyperglycemia are associated with a 2 to 3-fold increased risk of cardiovascular complications. So you have to look at cardiovascular risk factors, control hypertension, control of lipids, use aspirin when it's needed. And if we know that these patients who are obese with high cardiovascular risk are associated with complications, treat obesity early on, treat overweight. Why wait?
Thank you for listening to this Medea podcast. For more information about our continuing medical education programs, please visit our website at medeaacademy.com.